Okay, Assalamu alaikum and good morning to one and all. So this is basically the part 2 of anti-Parkinson drug. So let's quickly revise what we have studied in last lecture. So we have seen that the Parkinsonism, it is progressive neurodegenerative disorder which is generally seen in case of the elderly patient. So that is the characteristic which is seen in case of elderly patient. Then we have studied about different symptoms of Parkinsonism. So four important symptoms we have studied. First symptom we have studied was the muscle rigidity, then tremor, which is especially the peel rolling tremor, that it is something like you have kept the peel on your thumb and you are rolling with your index finger. So that type of movement it is seen in those patients. Then we have studied about the hypokinesia, that is decrease in the movement in the patient. And we have also studied that the patient show characteristic shuffling gait. So that was the fourth symptom of the Parkinsonism. We have also studied about different causes of Parkinsonism. So first was ischemic disorder, where there is less supply to the brain is there. So it may lead to partial necrosis of the particular part of the brain which is responsible for the controlling the movement of the body. Since there is the necrosis of that tissue because there is no blood supply, there is no nutrition and oxygen supply due to the ischemia, and that part of the brain it is partially degenerated and it may also lead to the Parkinsonism. Then we have studied another cause of viral encephalitis, where due to viral infection it produces inflammation of the encephalon, and due to inflammation of the encephalon it may also produces the Parkinsonism or Parkinson type symptom. Okay. Then we have studied third reason was the drug induced. So those drug which decreases the level of the dopamine. So all those drug which decreases the level of the dopamine can also produces the Parkinsonism. So we have seen few example like antipsychotic drug like chlorpromazine and the rezapine. So in such cases at overdose or when you take this drug for more time, maybe for the chronic treatment, it may lead to the Parkinsonism or it may start showing the symptom of Parkinsonism in that particular patient. And lastly, we have studied that sometimes the Parkinsonism it is genetic in nature. It runs in the family, and due to the mutation of two important gene, that is parkin and cycnuclein, patient may suffer from Parkinsonism. So this is what we have studied in the part 1 of anti-Parkinson drug. So today we'll study part 2 of anti-Parkinson drug. I am Professor Sheikh Abu Sufyan. Welcome you to AS Academy Learning Forever. At the end of this e-learning session, you are able to discuss neurochemical theories and pathogenesis of Parkinsonism. We'll see in a detail about these neurochemical theories, then give its classification and explain why LEVODOPA is used in a combination. So let's start with first, that is neurochemical changes. So before going ahead, let me tell you that all neurochemical theories or all neurochemical changes that we know, it is specially based on some evidences. So there were some evidences which were studied on the patients suffering from Parkinsonism, and based on those evidences different theories were proposed. So first important theory, it is the dopamine theory, which say that decrease in level of the dopamine may be responsible for the Parkinsonism, and there are some changes in the specific part of the brain like basal ganglia which control the motor nerve which is responsible to control our movement, and due to that degeneration patients suffer from Parkinsonism. So first evidence, it is quite clear. The Parkinson disease, it affects the basal ganglia. So this portion of the brain, you can see this, it is called as the basal ganglia. So all those part of the brain come under the basal ganglia. If there is degeneration of that particular part which specially control the motor nerve, patient may suffer from the disease of the movement, that is Parkinsonism, right? So this is the first evidence that Parkinson disease affect the basal ganglia of the brain. The dopamine content of substantia nigra. So again, substantia nigra, corpus striatum, so both are the part of the brain which come under basal ganglia. So in this portion they come, that is the lower part of the brain. Okay, so the dopamine content of the substantia nigra and corpus striatum in post-mortem brain of patient with Parkinson disease was extremely low. So this is again one more evidence, and it is observed that the dopamine content, it is usually less than 10% of normal. So if the dopamine content of this part of the brain, if it is less than 10% of normal, patient may suffer from Parkinsonism. Okay, so this is one evidences which is related to basal ganglia and dopamine. Next evidence which suggests that about another neurotransmitter, in case of noradrenaline and 5-HT, it is observed that it is much less affected than dopamine. So more important neurotransmitter in case of Parkinsonism, it is the dopamine. There is no much change in the level of noradrenaline and 5-hydroxytryptamine. It is seen in the patient with the Parkinsonism, right? Now, Parkinson patient, the patient suffering from Parkinsonism, doesn't immediately start showing the symptom. It is progressive disease, so that we have seen in case of definition, right? So slowly or gradually the patient starts showing the symptom. Now let's see when patients start showing the symptom. So the later studies have shown that loss of dopamine over several years. So this is very important. So the loss of dopamine, it does not happen suddenly, it is happens for several years, and the symptom of Parkinson disease appear only when the striatal dopamine content fall to the 20 to 40% of the normal, right? So maybe for 5 years, 6 years, or maybe 10 years, this dopamine content of the striatum, it keep on decreasing, but patient doesn't show the symptom, or he may show very partial symptom that sometimes you may not able to recognize, isn't it? But when patient dopamine content fall below 20 to 40% of the normal in the striatum, then only patient start showing the symptom of the Parkinsonism. So this portion again I have highlighted in this color. Okay, so this is the part of the basal ganglia, right? This is the nigrostriatal pathway, the striatum that I have mentioned, which is affected by the Parkinsonism. Okay, so the fall in the content of this entire portion, that is the striatum, below 20 to 40%, it may lead to the Parkinsonism. Let's see another evidence. There is the lesions. So lesion means what? There is injury. So lesion of the nigrostriatal tract or chemically induced depletion of the dopamine in experimental animal also produce the symptom of Parkinsonism. Now where is the nigrostriatal path? So this is your nigrostriatal path of the brain. So this portion, right? So here there are different neurons which are supplied in a group, and those neurons are responsible for the movement or the motor function. So if there is lesion or injury to this portion, or the chemically induced depletion of the dopamine, you are given the chemical which produces decrease in level of the dopamine in experimental animal also produces the symptom of Parkinsonism. So this is one more evidence which is in support of the dopamine theory that suggests that decrease in level of dopamine may lead to Parkinsonism, because when you give the chemical which induce depletion of dopamine in experimental animal, those animals start showing the symptom of the Parkinsonism. So as I have mentioned, our all theories are based on the evidences. Let's see how the symptom it is related to particular neurotransmitter. For example, we have seen the 4 symptoms. All symptoms are not related to the decrease in level of the dopamine, right? So the symptom most clearly related to the dopamine deficiency, it is the hypokinesia, that is decrease in the movement in the patient. So patient walks slowly. The movement it is difficult to initiate, and once it is initiated, difficult to stop. So this is called as the hypokinesia. So it is occur immediately in case of the lesion animal. So when you produce the lesion of the nigrostriatal path, so this can be produced by giving the injury by using stereotaxis apparatus in the animal. So what this indicate? The main neurotransmitter which work in nigrostriatal path, it is the dopamine. So if you produce the injury of the nigrostriatal path, it produces the deficiency of the dopamine, and due to deficiency of the dopamine, patients suffer from the hypokinesia. But this is not the only symptom. There are many other symptoms are there. Let's see what are those symptoms and how they are related to different neurotransmitter. Next symptom, it is the rigidity and the tremor. So we have seen the patient have the muscle rigidity, patients show the pill rolling tremor. So when scientists they studied about these symptoms of the Parkinsonism, so it is observed that it involves more complex neurochemical disturbance. There is not only involvement of the dopamine, especially the neurotransmitter like acetylcholine, noradrenaline, 5-hydroxytryptamine, GABA, as well as dopamine. When they also involve, then patients start showing the symptom of the rigidity and the tremor. So first we have seen dopamine deficiency produces the hypokinesia in animals, so that clearly could indicate that The hypokinesia, it is due to deficiency of the dopamine. So it's depend what type of symptom patients show, and based on that you can decide what treatment can be given, how you can start with the pharmacotherapy. In addition, it is also seen that there is involvement of intrinsic cholinergic neuron. So this is very interesting about the involvement of the cholinergic neuron, especially of the corpus striatum, right? So again, this portion of the basal ganglia, that is the corpus striatum. So this is the striatum, so you can see here, right? So the intrinsic cholinergic neuron of the corpus striatum are also involved in the Parkinsonism. Let's see what is their relationship between Parkinsonism and acetylcholine. Okay, so acetylcholine release from striatum is strongly inhibited by the dopamine. So must remember, the dopamine and acetylcholine are counter-regulatory neurotransmitter. What it means? Suppose I'm writing here dopamine as the DA. So if there is increase in level of the dopamine, so suppose the level of dopamine is increased, then due to increase in level of dopamine, automatically the level of acetylcholine will decrease. So this is what the counter regulation is. So excessive level of the acetylcholine in the brain, it is controlled by the dopamine. So when the level of dopamine is increased, level of acetylcholine will decrease. But what is happening in the Parkinsonism? Parkinsonism, level of dopamine, it is decreased. So since the level of dopamine is decreased, automatically there will be increase in level of the acetylcholine, because acetylcholine and dopamine, it is counter regulatory neurotransmitter. They regulate the level of each other. So there is hyperactivity of the cholinergic neuron, which is associated with lack of dopamine, and this lead to the symptom of Parkinson disease, right? So if you want to give the treatment of Parkinsonism, what you can do, either you can increase the level of the dopamine, or you can decrease the level of the acetylcholine, so that you can able to control different symptom of Parkinsonism. So this is all about neurochemical theory. So to conclude or to summarize, the neurochemical theory, it is run around two important neurotransmitter. One, it is dopamine, second one, it is acetylcholine. So level of dopamine in all the evidences, it support the dopamine theory, that is decrease in level of dopamine may lead to Parkinsonism. Also there are few evidences which show that there is hyperactivity of the acetylcholine, which may lead to decrease in level of the dopamine, and patients show the symptom of the Parkinsonism. Whereas involvement of the other neurotransmitter, it is very rare, and that is seen only in case of the tremors and muscle rigidity. So these are all about neurochemical theory. Let's quickly see about the pathogenesis, that is again important. So I am revising this because this you already studied in second year CNS chapter, but it is very important to understand pharmacology of the drug. So I am going more into the detail of the pathogenesis and how the patient suffering from the Parkinsonism. Okay, so let's quickly see. So first important parameter, it is environmental factor, and second, it is hereditary parameter. So this we already seen, that involvement of the parkin and synuclein, these are the gene which undergo the mutation, and in the case of the family, if that mutation, it is predominant, so mutation of parkin and synuclein, it is predominant, then those family members suffer from the Parkinsonism. So that is called as hereditary Parkinson disease, which run from family to family. Right? And another important parameter, it is environmental factor. So earlier it was not known that the environmental factor is also responsible for Parkinsonism. So there is very interesting story is there behind this, so we'll see that. So before that, we'll see what happened. Like suppose if there is involvement of environmental factor or hereditary parameter, no matter which cause is there, but patients suffer from three important factors which lead to the Parkinsonism, or which lead to damage to the dopaminergic neuron, basal ganglia, nigrostriatal tract. So the damage, it is caused by three important factors, namely excitotoxicity. What is excitotoxicity? Excitation of the brain. The more excitation of the brain, it also produces the necrosis of the CNS. So if there is more excitation is there due to hyperactivity of the particular receptor, or maybe due to release of more neurotransmitter in particular portion of the brain, it produces the excitotoxicity. So that portion of the brain, it may undergo the necrosis. It may be due to the oxidative stress. So in oxidative stress, there is a release of more free radicals, which form covalent bond with the body tissue, which is responsible for the necrosis. So if there is more free radical in the brain, These free radicals form covalent bond with the brain tissue and it produces the necrosis of that particular portion, because once they form the covalent bond which become a permanent, and it produces the necrosis of that particular tissue, right? And last option, it is the apoptosis. Apoptosis, it is the cell suicide, which is not seen in all the patient, which is seen only in case of the few patient, right? So no matter what reason is, whether it is environmental factor or hereditary parameter, in the brain these three things are happening. One, it is excitotoxicity, oxidative stress and apoptosis, which produces damage to the brain. So let's see the very important parameter, that is environmental factor, and what is story behind this. So in 1982, the group of young drug addicts in the California, they suddenly developed the frozen addict syndrome. What happened means, after taking that is the drug, especially the heroin, those patients will suffer from frozen addict syndrome. Means wherever they are, they stay there only. They were not able to move. They were not able to sit. If they are standing, they are not able to sit. If they are sitting, they are not able to stand. So they are completely frozen. Okay, so they develop this frozen addict syndrome, and then it is observed that the heroin, that was the drug taken by those patients, it was contaminated with the environmental pollutant like 1-methyl 4-phenyl 1236 tetrahydropyridine. As it's difficult to remember entire name, so you remember that it is MPTP. Okay, so it is methyl phenyl tetrahydropyridine, so I call it as a MPTP. So it was observed that those patients who have taken the heroin, that heroin was contaminated with this MPTP, and the MPTP, it was responsible for this frozen addict syndrome. So then the scientists, they have searched, they did the research, and they find out what is mechanism behind the Parkinsonism or frozen addict syndrome, which is almost same to the Parkinsonism. It is seen in those patients. So what is the reason behind it? And they observe that when MPTP is given to the patient in the body, in presence of the enzyme that is monoamine oxidase, it is also called as MAO. I am writing here so that you can remember, it is called as the MAO enzyme. Okay, so because there is one more category of anti-Parkinson drug which is called as monoamine oxidase inhibitor, that is called as MAO inhibitor, isn't it? Because what they does, they inhibit this cycle. So MPTP in presence of this MAO enzyme, that is monoamine oxidase enzyme, it convert into MPP plus. Now MPTP, it is converted into MPP plus. So now when plus sign is there, these become a free radical. This MPP plus is taken up by dopamine transport system. So very interesting. It is not going anywhere. It is selectively taken by dopamine transport system. So it will obviously go to the dopaminergic neuron. It acts selectively on dopaminergic neuron because it is taken up by dopamine transport system. It is going through this transport system into dopaminergic neuron and produces the oxidative stress. Why? Because this conversion of MPTP into MPP plus. So this MPP plus, what it is? It is the free radical, and oxidative stress, it is due to a free radical. So once it is converted by the MAO enzyme, this MPTP, this MPP plus will be taken up by dopamine transport system. They are selectively go into dopaminergic neuron and produce the oxidative stress. And due to oxidative stress, it produces it selectively destroy nigrostriatal neuron. So nigrostriatal neuron, it is important part of the basal ganglia which control the movement of the body, and due to that, those patients suffer from frozen addict syndrome. They were not able to walk, they were not able to move, and similar kind of symptom can also be produced in case of Parkinsonism. So then they realized the MPTP might be responsible for the Parkinsonism. One more evidence which support this MPTP involvement is when you give the siligyline, which is a selective MAO-B inhibitor. Siligyline, it is selective monoamine oxidase B inhibitor. When you give this, it block conversion to MPP plus and prevent MPTP induced neurotoxicity. So although you are given the MPTP, but along with the MPTP you are given selective monoamine oxidase B inhibitor in the animal, and when you are given this, since it block MAO enzyme, there is no conversion of MPTP into MPP plus. So it block conversion to MPP plus and it prevent all MPTP induced neurotoxicity. So this evidence also strongly say that there is strong involvement of MPTP, that is one of the environmental toxicant in case of Parkinsonism. So if the hereditary is not a reason, if viral encephalitis is not a reason, then might be or environmental factor, it might be there behind the Parkinsonism in that particular patient. So it is used in case as experimental tool, so it is given to the animal to produce Parkinsonism, and then you can give the drug to test how drug it is reducing the Parkinsonism. So it is very good experimental tool to induce the Parkinsonism in case of the animal. There is one more evidence which is related to rotenone. So rotenone, it is the herbicide. It is used especially in case of the farming. So the rotenone, it selectively inhibits mitochondrial function and also produces Parkinson disease like syndrome in case of the animal. So this one more evidence, it support involvement of environmental parameter in case of Parkinsonism. Okay, so these are all about the evidences which suggest environmental toxin could be a factor in human Parkinson disease. So we are done with the pathogenesis. Let's go to the classification. So all anti-Parkinson drug, you must remember what they're doing. They act on two important neurotransmitters. So the first neurotransmitter, it is the dopamine. So you want a drug which can increases the level of the dopamine, okay? Because Parkinsonism, there is decrease in level of dopamine. And you want a drug which can decreases the level of the acetylcholine. So you can use either both the drug or you can use either of the drug based on how patient is responding to the therapy, right? So for example, if you use the drug which act on only dopamine and patient is not responding, then you can go for the combination therapy, right? So first category, it is the drug that replaces the level of dopamine. Example, it is the LEVODOPA. It is used concomitantly, means it is used along with the combination with peripherally acting dopa decarboxylase inhibitor like carbidopa and benserazide. So we'll see later on what is the reason. So you must remember, we have used the LEVODOPA. In the brain, it is converted into dopamine. Okay, so LEVODOPA, it is their isomer. When it's going to the brain, it is converted into dopamine and increase the level of dopamine. So our purpose is solved. Next category, inhibitor of catechol orthomethyl transferase, that is COMT. Example, entacapone. It is also used to inhibit dopamine inactivation. So this is the drug which inhibit the enzyme, that is catechol orthomethyl transferase, which produces the metabolism of dopamine. So if you can inhibit the metabolism of dopamine in the brain, it can increases the level of dopamine. Third category, drug that mimic the action of the D2 and D3 receptor. So the drug which activate this receptor like bromocriptine, pergolide, lysorides and pramipexole. So this is the third category of the drug. Again, it's act on the receptor and it produces the activation of the dopaminergic receptor. Fourth category of anti-Parkinson drug, it is MAO-B inhibitor. Why we are giving MAO-B inhibitor? MAO-B inhibitors are important to avoid environmental toxicity, or if the patient has the possibility of the Parkinsonism due to environmental factor, then that can be avoided. So very good example, it is the siligiline. So we already studied this, how it works, because it inhibits conversion of MPTP into MPP+. Likewise, it avoid conversion of many environmental toxicant into its the free radical. So you are giving it as a preventive medicine. In addition, you are using the drug that release the dopamine. So example, it is the amantadine. Basically, amantadine, it is the antiviral drug, but in addition to antiviral action, it also releases the level of the dopamine in the brain. So you can use that. And last one you can use, it is muscarinic acetylcholine receptor antagonist. So these are the drug, what they are doing, they decreases the level of the acetylcholine. So this is only one category we are using, whereas most of the drug that act on the dopamine, they increase the level of the dopamine, or they may activate the dopaminergic receptor, right? Whereas this is only the category, that is muscarinic acetylcholine receptor, which decreases the level of dopamine. So now when level of dopamine will acetylcholine it is decreased, what will happen to the level of dopamine? Level of dopamine will increase. So this is the classification of anti-Parkinson drug based on their pharmacological action. Okay, so let's see our last portion, why we are using the LEVODOPA in the combination. So first remember that the LEVODOPA, although we need to use it in a combination, but it is very good drug which is the first line treatment for Parkinson disease. But the problem with the LEVODOPA is that when you give the LEVODOPA in presence of enzyme decarboxylase, in the periphery of the intestine, means when you give the tablet of dopamine, in intestine in itself, this levodopa is converted into dopamine. Why? Because there is presence of decarboxylase enzyme in the intestine. Since it is converting into the dopamine in intestine, due to that, so most of the drug it is inactivated by the MAO enzyme. So MAO it is present in your GIT, which inactivate this dopamine, and it account for about 95% of the levodopa dose, right? Since it is inactivated by the MAO enzyme, your 95% of the levodopa it itself degraded into your intestine. It is not even reached to the brain, because your target is brain, not an intestine, right? So only 5% is reaching to the brain. So to avoid that, what you can do, you can give the drug which can inhibit this enzyme decarboxylase. So if you can do that, there is no conversion of levodopa into dopamine in the intestine. Rather, it will go into the brain, and there it will be converted into levodopa into dopamine, right? So this is one thing. Second thing is that when levodopa is converted into dopamine in intestine, this excessive level of the dopamine in the intestine, it produces very troublesome side effect of the GIT, right? There is maybe patient may suffer from hyperactivity of the intestine, because dopamine it is related to the intestinal motility. It produces the hyperactivity, and due to that it produces the troublesome side effect in that patient. So to avoid both things, that is inactivation by the MAO-A, and to avoid troublesome side effect which is related to levodopa, so to overcome this, levodopa is combined with peripheral dopa decarboxylase inhibitor. Okay, so these are the peripheral dopa decarboxylase inhibitor which act only in the intestine, not acting in the brain. So you have saved your 95% of the levodopa dose. So 100% going to the brain, or near about 100% going to the brain, and also you have avoided troublesome side effect which is occurred due to the dopamine. So this is the reason why levodopa is always given in a combination. So it is combined with peripheral dopa decarboxylase inhibitor, carbidopa and benserazide, right? So when you give in a combination, it reduces the dose needed by about 10-fold. It reduces the dose of levodopa and diminish the peripheral side effect, right? So all those troublesome side effects are also diminished. So this is one combination that we are using in case of the levodopa. But decarboxylase inhibitor means benserazide and carbidopa, they do not penetrate the blood-brain barrier. Since they do not penetrate the blood-brain barrier, when levodopa goes into the brain, there it undergo the process of decarboxylation. So in the brain, decarboxylation it is occur because decarboxylase inhibitor does not go into the brain. Since they are not going into brain, in the brain there is conversion of levodopa into dopamine, and your purpose is solved because you want to increase the level of the dopamine. So this is one of the combination. In addition to this, the levodopa they are also combined with the COMT inhibitor. So why you are giving COMT inhibitor? So COMT is catechol orthomethyl transferase. It produces the metabolism of the dopamine. So now levodopa in the brain it is converted into dopamine. Now you don't want dopamine undergo the process of metabolism. So to avoid that, what you can do, you can give the COMT inhibitor which avoid the conversion of dopamine into its metabolite. So whatever drug you are given, that is levodopa, that will convert into dopamine, and that dopamine remains as such in the brain for more time if you are giving COMT inhibitor. Otherwise, the problem is that the levodopa having very short half-life, that is 2 hours. So since it having only very short half-life, anyway you want to keep that concentration of dopamine alive. So to keep that, what you are doing, although levodopa is converted into dopamine, that dopamine level remains intact when you are combining levodopa with inhibitor of the COMT, example entacapone. So it's shown to improve clinical response by inhibiting degradation or metabolism of the dopamine. So this is how the combination of the levodopa with dopa decarboxylase inhibitor and second category, that is COMT, it helps to maintain the level of the dopamine intact in a brain, and which help to reduce the symptom of the Parkinsonism. So I have done with my today's session. So